program, I think the decision post-residency what to do is the most crucial because it involves cost and time on part of the person who is committing to a fellowship program. So, having decided that one needs to do the fellowship, I shall be presenting based on these subheadings. So, coming on to how do you choose a specialty? I think the most important criterion obviously has to be your personal interest. What excites you the most in the fellowship per se? Obviously, if you are a bit undecided, given that the knowledge itself is diversified into almost 8 specialties that you are choosing on which particular specialty, you could always lean on your mentor to guide you based on the assessment of your skills, your aptitude, and the interests. What also is a very important factor is where you want to set up your practice. Will you be joining a private practice or will you be joining an institutional kind of practice? It's important because in an institutional practice, you can actually go to a very niche specialty and concentrate only on that. Whereas if you're going into a private practice, you might want to lean towards more on the comprehensive side where you would be the jack of all trades. What is also important is the place. Doing a very niche ocular oncology kind of practice in a Tier 2 or Tier 3 city may not be the most viable in terms of career options. Choosing the fellowship based on your own personal interests as well as the demands. So obviously the market forces also play a very important role when you decide. If you are trying to go to a particular city and you know that particular specialty is a little less represented, maybe you can try and take up that as a specialty and work towards that. But majority in India do take a fellowship just to augment their deficiencies in the residency training, and that's a sad state of affairs. Hopefully, with the AIOS and other international bodies paying attention to this, the residency program in medical colleges will also improve. So, once you have joined a residency program, it's always important to align your training so that you work towards your fellowship. So, maybe if you have a choice, you could actually choose a thesis topic on the subspecialty that you would like to pursue. Obviously, this would require your HOD or the thesis guide's approval, but if you are able to get that, that actually helps you because you will be doing very deep study over the next 3 years on that subspecialty. Ideally, can influence could also be requesting for the posting in that subspecialty towards the second year of the program, because that's when you have a better understanding of the subject and you will be able to interact better with the faculty and clear up most of your doubts. Very important to keep talking to all your mentors, the faculty, and seek guidance on closing in on a particular fellowship. There's no substitute to hard work for gaining what you would wish to achieve. I shall not be speaking too much on the research publication because we have Santosh will be speaking on that. But obviously, what need not be emphasized is any publication or research in your chosen specialty actually is a statement of interest. That's how you would be selected for your certificate fellowship program. So, what one needs to do is obviously network a lot. Network at conferences like this, your media conference, or this specialty conference, where you meet with other residents. Residents are probably the best way you can get information about a particular what kind of work that is being done in either institutes or medical colleges or at a particular clinic. You also need to hear to leaders and pick their brains, especially if you have a breakfast session or the other kind of session where you have more personal interaction with the mentors. These would then be your potential mentors for the future. So, networking is very important. Then comes the decision of choosing either a mentor or the institute. Now, mentor is an absolute authority in that particular field, and we have many such mentors who are doing phenomenal work in the private sector. So, not all fellowships need to be institute-based, but actually choose a particular mentor, whether he is the private sector or an individual practice.
Sure, sure. Hi, good morning, ladies and gentlemen. Hi.
So obviously, the advantage of being with an institute is you have an array of mentors. So overall, the specialty work is much better. You can choose from a bouquet of specialists to train under. What is also important to understand is the duration of fellowship programs. And in India, we still don't have a very structured fellowship program across the country. So it could vary from 1 year to almost 3 years in the same specialty. So choose a program which suits your requirements. Ideally, for a specialty, it could be anywhere between 18 months to 2 years is a good investment period for taking it forward. You also need to see is how is the academics at that particular institute, because that's where you will be spending 2 years of your concentrated work, and you would need a subspecialty which or an institute where the academics is very important. You should also have good opportunity to do research and publication. As I said, these are absolutely vital for your series. Last but not the least is obviously the skill transfer, the hands-on training that has been offered in the institute. Some of the institutes have a structured program where they would specify the number of cases of a particular type that you would do. Others would have a much more general based on your personal skill sets and aptitude. So, when you come out of the medical college, you also have an option of going on to a senior residency program. And senior residency programs, especially in institutes like PGI or an AIOS, are very good. The only difference from a fellowship is the opportunities are limited here for senior residency. You commit to at least 3 years to the senior residency program, and it makes you into a good comprehensive ophthalmologist. Some specialty work may be a little lacking in these programs. Obviously, it does help you if you want to have a career in medical colleges or in the government sector as a senior residency, which is very different from a fellowship program, which is more structured. There is more of training as opposed to the teaching, which has a higher emphasis in the senior residency program. So in comprehensive fellowships, the duration could be anywhere between 1 year to 3 years. You need to have minimum sort of qualifications. Obviously, the main merit of comprehensive fellowship is it fills up the deficits of your previous training programs. You have a much more holistic approach for patient management and also the clinical and research exposures. This could actually be a platform or a basis on which you can subsequently plan your super specialty fellowships. It also has opportunity for you to write various exams like the ICO or MARC for their parties. The most sought after are obviously the subspecialty programs. Obviously, you get much more in-depth exposure both in the clinics and surgery in that subspecialty, and you could actually hone on your skills, get an in-depth knowledge. And obviously, it does help you with some of the specialty exams, the FICO or the ICO fellowship exams. Obviously, most of these specialties might restrict you from very comprehensive ophthalmology, especially if you are into a retinal fellowship. You might actually not be doing any capex in that program. This obviously is one of the demerits you need to choose when you want to do that. There are a host of institutes abroad also which offer this. Let's look at some of these. Now, obviously, the US fellowships are one of the most sought after. There are various ways in which you can get into this program, either through direct application or through the ICO. The easily sought or they easily got fellowship in the US in the research fellowship. That's also called as the observership. It does not require the applicant to have completed a US residency, and obviously it requires personal financing or a financing from the home institute. And this is something which is readily available for international medical graduates. Generally, it can be from 3 months to a year. The focus is more on research and teaching. You might get incidental surgical exposure as an observer in the OR, but no hands-on is allowed here. There is a very limited one-to-one patient interaction. So they are very specific and very particular about the exposure that's here. And obviously, you need to follow the local state laws. Getting fellowship into the clinical side is very, very difficult in the US. You will need to actually complete a US residency, and then you will also need to compete against the residents in the US itself. But having said that, if you are able to get into the clinical fellowship, there's nothing like it, because the surgical exposure, the exposure to the state of art, the latest technology, the research is much better here, but something which is very difficult. This could also potentially lead to an employment in the US itself. A much more easier way of getting into a fellowship is the UK fellowship, which now has something called as the DSS, the Dual Sponsorship Scheme, where the RCO acts as the sponsoring body to get registration into the GMC or the General Medical Council. And what's important is you need to be an active ophthalmologist in the past 5 years, at least 3 years of those past 5 years, in the last 12 months into active practice, and then you are considered for this program, and you need to pass in English aptitude test. But otherwise, this is something which is well sort of, and this is also partially funded by the institute itself. Coming closer to the Asia Pacific region, obviously Singapore is one of the most sought after, and you can get into this ICO programs in any of these, either the SNEC or the Toxel Hospital or the National University Hospitals. They also fund this fellowship program, but it's very difficult to get into a job after your fellowship. But in terms of training and exposure, this is the sort of, as also Australia and New Zealand, also these are some of the websites where you can actually apply for these fellowships across the region. So obviously, last but not the least, you need to have a CV, and the best CV is the number of publications, papers, and submissions that you have had. I think that is one of the most important, especially if it has a very good impact factor. I think half your job in the application is done. Obviously, you would need a letter of recommendations from eminent ophthalmologists, people of repute, your HODs. And obviously, while you have the interview, you need to convince the team why you're actually interested in the fellowship and why the mentor needs to spend time in it. So once again, thank you for your attention, and I invite all of you for our Retina Summit on 30th June 1st.
Thank you very much for a very extensive talk, Dr. Girish. I would take one question, but Saurabh will be there.
So one question, very nice talk, very good for the trainers definitely. I wanted to ask if you have any experience of exchange programs in fellowship or during post-graduation, and is it recommended and how to do it?
So we are right now, as an institute at Shankar, we are exploring this with Singapore SNEC. So I think it may be too early for me to really comment on how good that program is, but I think it's something worth exploring. We're right now looking at 1 month to 3 months exchange program, where the residents would exchange on a given subspecialty. But we are still in the discussion stage, so I may not be very qualified to answer that right now.
If supposing a person has thought of a particular fellowship program and he doesn't get it, would you advise that he waits for a year or 6 months to reapply, or should he move on?
No, I would recommend that he waits. In the meantime, he can work
As a research.
either in the research or as a comprehensive ophthalmologist, continue working. But then again, like people keep giving needs 2-3 times till they actually get it. I think we should Obviously, there are now a lot of options in the subspecialty also. Many people actually apply for 5-6 places and they keep hopping from one place to the other. So I think there are opportunities, but obviously it should be.
Are there programs for the trainers to get to enhance their skill sets in our country?
I'm not aware of any such.
We've got a trainers program.
Huh?
We've got a trainers program.
Yeah.
There's in different subspecialties. Like we've got trainers, we've got a specific program. And for the teachers, we started one. So we've got about 3 such programs where we call it as a trainers.
Thank you.
Just one question. So in all these subspecialty fellowships as well as the comprehensive ophthalmologist fellowship, definitely the greater depth would be given to each of those specialties. But is there any program where they can train for practice management, finance management, or something like that, where they touch upon things which they will go out into the world and face?
So I think LICO does that.
Like
LICO does that, but other than that, all our fellowships have some kind of training within the fellowship itself, but no exclusive program like this. But we have a basic program on health management, but that is more not just ophthalmology, but for paramedics or anything.
And the last question was your business. You know, there are fellowship programs where it is a 2-year or a 3-year program, and that some portion of it gets scattered into comprehensive. Do you feel that a fellowship program of student choosers should have a 2-year or a 3-year focused stay only on the subspecialty? Because even that 2-year or a 3-year is not enough for them to have learned it all.
Yeah. So as an institute, we feel that a 2-year program of concentrated subspecialty is ideal. We have a 2.5-year program where the first 6 months are research in that particular. But once the fellowship starts, we go uninterrupted. We do not send them to a comprehensive. So I strongly feel that should be.
Thank you. Thank you very much. Dr. Sushmita has a different program to go on to, so she will take on the next job. And she is the professor of the Department of Ophthalmology at PGI Chandigarh. And she is going to talk on something so very important. Mentorship might take the next 10 minutes. And that towards the closure of my term, I want to really personally thank Sushmita for being such a major ace card for me in all my dogma meetings and webinars. Thank you, Doctor. Thank you for the opportunities. We're waiting for our slides. So just one comment on the last thing that we talked about. I think the problem arises when we are running a fellowship program due to the varying capabilities of the person coming in. So that's why I think at least the first 6 months, if you get everybody up to the same level, because unfortunately especially surgical exposure is such that when we run a government fellowship and we've also had a stipulated 2 years senior residency. But believe you me, a 2-year senior residency at any major institute, vis-a-vis any medical college or anywhere else, some of them are simply not average. So people who don't have a surgical exposure at all, for us to say that okay, go ahead and do a track. So that's the reason why we realized that for us that learning fellowship is very strenuous because it's just 1 year. That's
and
why I thought.
yet even Goldman application to geometry and bronchoscopy is not part of their curriculum. But if you're going to start there, then it is that's the only thing of maybe. Right. Having said that, thank you very much, and thank you, Dr. Chitra, as always. It's been a pleasure. My take on mentoring, I mean, I really had to think out of the box. I wish there were things to tell me what to talk on this. The problem is I don't have any mentoring coaching, so I'm no expert at what a good mentor should be. I'm completely old school, as spare the rod and spoil the child. So that's what our teachers were and our parents were, and very much that's what we learned. But then times have changed. So hands-on mentoring is what we learned along the way. And actually, my greatest teachers have been my children. From the time that they've been very young, most of the experiences in mentoring are like I handled my children until they've grown up and flown the nest. So I realized that with our postgraduates, it's very much the same. What I learned does not work is wait for someone to ask. It's not easy for a postgraduate or a junior fellow to come up and say, I have this problem. So they are not going to wait. It's up to us to pick up the signs, much as we would tell a child who you know, what happened, why aren't you talking today? Or what happened, why are you talking so much? Depending on what they are. So if you're having trouble, it's okay to ask for help. And that's one of the first things we tell our new, freshly minted graduates in. Because mentorship is also an active choice. And if we think that we're going to sit in a booth and say, okay, I'm available, come to me, that's rarely going to happen. So who exactly is a mentor? A mentor shares knowledge, skills and experiences. I think that's the main thing. Knowledge and experience, probably the internet would and the AI would provide, but it's the experience, it's this grey hair, is what I think differentiates a mentor from a coach, which will soon come to me. So it's often confused, coaching and mentoring, and I just put this really slide in, but I thought it was really interesting because a coach is more performance driven and goal oriented. So how many did have you do today? And how many papers have you published? And did you manage to get that case reported? Or picture liking? Did you edit your video? A mentor emphasizes continuous development. It's not what did you do today, but it's what you have developed into as whatever you meant to be. A coach is to improve a certain skill or reach a measurable milestone. I think that's what our fellowships are. That you come like this and you should be able to do 50 cataracts, you should be able to do 10 traps, you should be able to do 5 sprints. That's what coaching is. But the mentee, when you help them develop a wholesome understanding of professional growth, what is it that you want to do in life? Will you be able to manage 2 small children or 3 small children? Will you be able to go to a tier 2 or tier 3 city without support? Coaching sessions, of course, are the more rigid structure. Mentoring can be both semi-rigid or it can be semi-structured as well. A coach has a clear instruction of action plan. You need to do this. A mentor doesn't impose decisions. It provides counseling and guidance. And for a coach or a coached person is expected to follow the coach's plan. Why did you do this? That's a coach. But a mentor usually, the mentees, it's up to them to decide, but this is what I think. I think that is the fine line between what I've understood is between coaching and mentoring. And usually a junior person or a junior resident would be more inclined to be coached, but a senior resident or a fellow has had his thing and it's more likely to require mentoring. That I have this idea, but can you tell me if it's okay, depending on what you've seen or what you've heard? So the ideal mentor would be a guide. And of course, Snoopy is my mentor. He is so wise. Snoopy, Winnie the Pooh and Edith Wright. They've really shaped the lives of children of our generation so much. So I'm using a lot of Snoopy in. It's a strategist, a resource person. So that's the resource person. A listener, a good conversationalist, a confidant. It's okay to come and tell me your problems. I won't tell them to anyone else. And a cheerleader. And how can this effective mentoring be achieved? One is set definite goals, have a regular feedback, and have an open communication. It's not enough to say that a protocol every week or every fortnight, how much have you finished? How much is done? How much have you even understood what you need to do? So set the goals and then reach them. And then we also need to ensure that we provide constructive criticism and help the mentee develop their strengths. So it's okay to ask, what are you up to? And it's okay for that mentee to say, I'm sorry, it's just not my day today. So that's okay. And that's what the mentor needs to understand. That all right, I understand it's not your day today, but kal leke aana hai. I'm not going to listen to this again. So are there benefits to mentoring? One is of course career development and personal growth. The amount a mentor learns because they have to teach is amazing. The amount I learn if I have to make a presentation is also amazing. Networking opportunities, as was told by Dr. Dinesh just now, it helps build a sense of community. You know, you're part of it. You've done pediatric glaucoma, you'll do a goniotomy, your mind, you know. So fosters a culture of learning as well. And there's a positive impact as a whole. And it's nice to think I make the world a better place because I am a positive person. So my take on all what a mentor should be would be a guide. I think you should do this. A strategist, I think you could focus on this plan first. A resource person, I have that information, I'll share it with you. A listener, yeah, that's a good idea. I think we can do that. A confident, it's okay to tell me what's troubling you, I won't tell anyone else. And of course, a cheerleader, don't be scared. AIOS, you'll do much better. You're better than most. You'll do better. Don't be scared. So to conclude, I think mentorship's been a beautiful journey, still continuing, just about started. It takes time and effort, but the rewards are worth it. And by building stronger leaders, we create a culture of continuous learning and development. But I realize we need to be patient, empathetic, and willing to share knowledge and experiences. Thank you. I'm always here, but I love to see people happy and succeed, and that's what a mentor should be. Thanks a lot.
No, you bring in so much energy to my webinars. I think you must be a great mentor yourself. Just one minute. I would want this question to be taken by Dr. Girish Ram and also Dr. Sauler. Now, do you think mentorship is something not just during the 2-year period, but it would be ideal if it becomes a lifelong commitment of the mentor with that student, or is it something just a impossible thing to be expected of?
So I think it does work that way, most of the cases. But the only problem is once the fellow moves on to practice, it's very difficult for the mentor to keep a check on that. But it's the mentee who keeps
Getting back.
and it's for the mentor to be available at that time, whenever. And I have my residents, my fellows who are now in other institutes who have called me in the middle of the study that I'm stuck here, what should be done? So that kind of commitment should be there. Mentor also to be able to reach out to them. That gives them the confidence that yes, there is someone in the backup to take care of this. I think it's an ongoing process, but very difficult for the mentor to keep a time and reach out to so many people.
But Dr. Sauler, how do you maintain the nobility which this role demands? And could you switch on the light between the talks and Dr. Namrata, you will be the next speaker.
I think mentorship is a lifelong process, and nowadays we have the opportunity to choose our mentors also. Because earlier, I think maybe 15 years back, we were restricted to institution where we are studying, and we work closely with many people, and we like few of them, and we idolize them. These are the people who we like to become when we grow old. Nowadays, that opportunity has even expanded because of of the social platform. So, a mentee should always follow the mentor. The mentor is also learning new things, because what I've seen, those people who maybe I have observed 10 years back, they might have changed their practice protocols, or way of thinking in certain things. And it's better to keep in touch, all throughout, so that you also become better.
Thank you. Thanks a lot, Dr. Sushmita. Thank you so much. Can the lights be on between the talks? Who is responsible? Audio visual? Light डालना है ना बात उधर. इसको बोलना है अंदर कंट्रोल नहीं है क्या? We shall now go on to our next speaker, Dr. Namrata Sharma, who leads to introduction, who has done an amazing job in her 6-year tenure as the Honorary Secretary of AIOS, and I'm sure in her next role, she is going to give us a scientific program to remember for the years to come. And she is going to be talking about training during fellowships, a continued education program schedule and the processes. Yes, Dr. Dr. Radhika, Dr. Ashok was born after her.
AIOC.
Thank you, Chitra. Thank you for taking such a wonderful program. And I would be talking to you about training during fellowships, continuing education programs, schedule and the processes. So I think I'm sure speaker before me has talked about it, the long-term fellowship and the short-term fellowship. Fortunately or unfortunately, there's not a very clear cut line, whether you do phaco-refractive or you do only phaco-emulsification or cataract surgery, or you do cornea and refractive, or you do only cornea. And also there is no structured program as per Medical Council of India also. I do remember Dr. Ashok Grover and myself, we had gone to meet Dr. Paul. Really is looking after all the programs of the postgraduate, and we wanted to see how we could accredit the fellowship program. But then he said it's a Pandora's box, and if we open fellowship program for ophthalmology, then we have to accredit fellowship program for all clinical specialties, and then it's a tough call. So we can't open that Pandora's box, to encompass everything. So that didn't really happen. So now the fellowship program is there across the country in various institutes, which are government, which are private, which are semi-private, and in varying specialities where some people will just give strabismus, others will add pediatric ophthalmology to it, and some only neuro-ophthalmology. So it's kind of not standardized. So having said this, I think after you do your post-graduation, one has to take a call on what one wants to do, because in normal surgery, I think everybody can do cataract surgery, everybody can do, but you have to do something beyond that. Now, if you have done a senior residency, then possibly you may not need to do a fellowship, provided the senior residency is in a particular subspecialty. Having said this, I do believe that it is always good to do some kind of a short-term fellowship, even if you have done a senior residency, at least abroad, because that kind of gives you a different confidence and it opens up new channels, and it's a different culture, so you learn something new. Now, there are ICO fellowships also available, which are only 3 months, but like I said, short fellowships, whether they are Commonwealth Fellowship, ICO Fellowship, or fellowships. These are given in several of the continents like US, like Australia, especially the Commonwealth Fellowships for people who are doing who are into government jobs. So you can go and avail these for short periods, and for a different kind of a way one tackles things, and also it also helps in future networking. The modes of subspecialty training, which we've already talked about, and I think what we are also looking at, and we have submitted, Dr. Sushmita spoke just now, and I'm sure she must have told you about the MCH options. Now MCH is available in PGI, Chandigarh, cornea and refractive and retinal surgery, and in RP Center also the MCH, we have now the courses have been submitted in all the 6 subspecialties to do MCH there. Apart from this, we also have the fellow of All India Collegium of Ophthalmology, FICO, the brainchild of Professor Arjun Azad, as well as Dr. Ashok Grover, who is very much here, and we do give FICO awards every year. I think the elements of the basic schedule of fellowship is induction and orientation, the basic subspecialty, winter-based training in the surgical techniques, and that is the focus of our fellows generally. Of course, clinical discussions and academic workshops is important, and as you go enhancing research and publication is also something which is important. Encouraging participation in international and national conferences may or may not be a priority, but that is the first step prior to research and publication. All of us, all the fellows should be in fact trained in emergency services, whatever fellowship they are pursuing. And some of the institutes also have a secondary center posting, which may range from few months to up to a year also. And of course, there are other rotational postings also, like in RP center. Out of 3 years, 6 months you are rotated in the periphery, which means ultrasonography, FA laser, medical retina, so that after you do your senior residency, at least you, in case you go into private practice, so that sort of option is also open. So Dr. Saurabh Patwardhan is sitting here, he's done from RP center, and he will know what I'm speaking about. So the components of the fellowship training are clinical skills, surgical skills, academic and research activities, public welfare activities, important to adapt to evolving technology, and also the administrative skills. It is often seen that people who are not so good junior residents are excellent senior residents. They have great organizational skills, they have great leadership qualities, and they completely transform their personalities when they upgrade or when they come into a fellowship program. Now, as far as the clinical skills are concerned, it is important to examine, to document, to know about the diagnosis, to make and explain the plan to the patient, to explain the plan to the patient, especially the prognosis, to answer all the patient's questions and communication skills is again something which has to be inculcated more so by the senior fellows, because that is something which is not taught routinely, and of course to perform a procedure or to give advice based on a medical pathology. Now, case presentations, clinical discussions, routine ward rounds, and bedside teaching, I think, has a lot of role to play. And of course, hands-on training and skill transfer is again something which is very important. And nowadays, they are teaching tools using modern technology, so things have become kind of simpler. Earlier, we had to peer to the slit lamp to see what your senior fellow is seeing, but now you can directly look at the monitors to see what he's trying to show you. I still feel that the senior fellows remain a very important link to teach you, because they are those people who can ask any kind of question and you don't hesitate at all. And in RP Center, it is kind of hand holding only. They all are a part of a group in various semesters. That means in various years, and there is a group leader who is the leader of the group, and all the cases, etc., which are presented are actually first discussed in the group, and then they come to the classes. So one building is already held within their group, and then subsequently they have to face the teaching program. Now, like I said earlier, acquiring various skills is important, and you may be doing a fellowship into cornea, but we still have posting of 6 months out of 2.5 years in lasers, in ultrasonography, in medical retina, even in community services, so that they acquire the basic skills and also they acquire something more, which when they go into practice is going to help them. Now, surgical skills is something which is very important, especially in a fellowship, because that is what you have come for. And I think it begins by assisting cases, and assistance of technology again has a very important role to play, and recording systems are there as well as monitors are there where people can watch. Now, there can be training into various kinds of surgeries, but I think cataract surgery is something where everybody trains right from post-graduation. And sometimes it is more important about surgical decision making, like in refractive surgery, and the actual surgery is not very much big deal. There are times when you may not be doing the cases on the wet lab, and there are simulators which are available, especially for anterior segment and posterior segment surgery, which help you to gain confidence, and prior to doing actual surgeries, one can try to do that. Then there are wet labs which are present. We have a wet lab at RP Center, and there are dedicated wet labs. Also, there is a dedicated wet lab now also at the College of Medical Society headquarters, which is called as the AIOS Prayogshalla. And the idea is again the same, to enhance the surgical techniques. Now, as far as the research and academic activities are concerned, these I think should be an integral part of our fellowship training program. After that, whether you want to do it or not is entirely optional. And again, one has to strengthen your basic knowledge, and active participation in the journal club symposia, case presentation is again something that is required. Now, for research and academic activities, documentation is the key. Active participation in the research projects. You cannot have the research projects yourself, but you may be a part of it. And of course, additional fellowship exams is something that is required. And this is to community, which may or may not be there. It is very important to adapt to evolving technology and to actually know what is, how to do it yourself, especially if you are a fellow. And independent, basically when you get posted into a secondary center, then you have independent management and independent skills. So it is important to enhance the multitasking skills which are encompassed as is shown here and which I have also discussed. And the goal towards the end of the fellowship should be confidence and comprehensive management of ophthalmic diseases, ability to manage complicated cases in that particular specialty, surgical competency, critical thinking, confidence in publishing papers and research activities, fulfillment or some amount of community ophthalmology training, and of course, figuring out the path ahead, which way you want to go in future. So thank you very much for your kind attention.
Thank you very much, Dr. Namrata. Question to Dr. Praseem and Dr. Saurabh. Do you think that besides the fellowship program, there should be some kind of a refresher course which is being offered time and again instead of just these CMEs which are often not even very structured? It's just a random collection of topics. So, do you think is there already a system or should there be a system? There's a mic there. Come in the front of your expert panel. AC.
So we were scared that it is going to be too hot. Now it is too much of
cold.
Yeah.
So I think I'm not aware whether there is any structured program for the fellowships and
No fellowship, I mean,
refresher
refresher courses.
courses. But definitely each institute has their own curriculum kind of a thing. They have their own SOPs and they follow those kind of SOPs for the for the refresher courses which they conduct and all over the country in various parts. And I think these programs should be a focused kind of program, and they are already focused on various subjects.
No, I don't mean about the program. I'm not questioning the fellowship. Much
No, no.
later on, should there be refresher courses
Yeah,
which
like,
should enhance.
in particular disease keratoconus management or dry eye management, such kind of things should be CME should be right in a structured way.
So you mean beyond fellowship?
Beyond
beyond
fellowship.
fellowship in various subspecialties, sub diseases.
I think, as you rightly pointed out, post fellowship, what happens is that when you complete your fellowship or senior residency, like I was very fortunate to be guided by Namrata Madam. But if you can visit, there are so many good institutes in India as well as abroad. So what I did after completing my senior residency is that every year I visit at least one institute, either in India or outside. Because you have already done your fellowship, you don't need a basic training elsewhere. But even an observership of a week every year, just put that 1 week out, and that can be even structured. That's what I was asking Girish Rao sir. If there is an exchange program between even fellows or TMB or MS resident, it will be a very good, because once you go to a different institute, it's a different approach towards the same specialty.
Ma'am, is there any standardized program in all the institutes as to the, for example, number of cataract surgeries that could be given in that fellowship?
I don't think there's a standardized program. Each institute has its own curriculum and has its own SOP for all the fellowships. I mean, there are no similar programs which are running, but I think by and large, all of them are going towards the same goal, and that is, the surgical skills should be there, the clinical skills should be there, and they should be able to handle it.
Globally, there have been efforts to have some kind of curriculum, some kind of a consensus on what the right figures are. We tried in Psycho in our curriculum to incorporate what we thought were minimum surgical procedures, minimum diagnostic procedures that should be performed in each fellowship. The committees worked on it and they gave their recommendations. They are all in the recommendations of the curriculum that has been laid down for subspecialty that is available on AIOS website under Psycho. But globally also I was part of that committee from ICO and later from OS where the curriculum was being developed. And the data was collected from various countries as to what the figures were. Most countries have set out some kind of a figure which they think is appropriate, but it's not achieved everywhere, but at least it is there as a standard which people have to show in their log books, so they may have some difficulty at least in saying that they have not done it.
Thank you, Dr. Namrata.
Ma'am,
Yes, Dr. Suhas and Dr. Grover, could you get connected?
just one question. So, Grover sir,
Dr. Suhas also needs to say something.
yes.
You can ask the question.
Yeah. So I was just asking Grover sir that are these fellowship training centers or hospitals they are recognized by MCI? Can we affiliate them to the AIOS or
That
what?
is what I said. MCI doesn't recognize any fellowship program.
Right.
They don't want to also. They only recognize postgraduate.
Okay, so the national board has done some like DNB, DR does exist in a couple of centers in the country. But most institutions did not opt for the reason that the mechanism of admission was only through the national board. So that is why it has not become very popular. There are other specialities also. For example, in plastic surgery, there are specialized areas which are all done either by national board or some even by the MCI, but they've not really gone into minor subspecialties or other specialties as well. And they are at this stage not even willing to go into it. In fact, they have not even spoken about subspecialties in the NMC draft that day. So I just suggested, and they have put in the word of subspecialties, but they have not tried to expand on it at this moment.
Yes, Dr. Suhas.
Yeah, talking about the refreshers course, especially after fellowship, I can talk on the cataract techniques. Very often I have realized that when we ask for someone who is already a paper surgeon and they apply for kind of refining the cataract technique, they come. And what we have realized is that we really need to take them through the basics. See what happens after the fellowship, right? Our fellowship all over the country are not standardized. So when the product comes out, it's not standardized. But then someone has learned paper, he continues to do paper for 10 years, then he comes to the question, I want to upgrade to CHOP. And when he comes, you have to literally take it through basic. That means refreshers course is necessary even in the operative techniques. Because they need to be
Now, the standardization of subspecialty programs, we were trying to work on it through Psycho. We have prepared a curriculum where the basics of structure required in terms of administrative setup, in terms of academic setup, in terms of equipment required have all been laid down. Manpower required have all been laid down. And we had laid down the period for which this should be done. And there is an effort on behalf of the AIOS, on behalf of Psycho to somehow maybe someday try and achieve it. So we'll need to create a lot of will for that and a bit of energy from the AIOS so that they're willing to provide the manpower to do that. But let's hope it can be done. Globally also, there was an effort to have the curricula were defined by ICO for subspecialties, and all these criteria were also laid down globally. But even to the start of subspecialty examinations on behalf of ICO, there was a lot of resistance. So we had to work through that resistance. Subspecialty examinations were started, but they've now again been discontinued with the ICU being in doldrums.
Thank you very much. We shall move on to our next speaker, Dr. Ashok Grover. He really needs no introduction. He is our past president and has been chairman ARC in his time, and he knows how valuable this this term is, and the kind of inroads he made into it during his term is something we still remember. And he is going to be talking on the basis for opting for higher education programs beyond postgraduate degrees.
Thank you, Jitra, for giving me this important subject. Much of it has been covered by the previous speaker, so I'll maybe emphasize certain points which were not emphasized. Making the right choice after post-graduation depends on what your career goals are. There are various factors that influence that decisions, and you need to know what the options are and which option is the best take for you. So the career goals may vary from a person's goal may be more of gaining fame, respect. For another one, it may be financial security or financial dominance for an individual, or it will depend on whether he has that santusht personality or whether he is the go-getter. So that is what will essentially be important. And it will be determined by his academic background, his background in the schooling, in undergraduate, postgraduate courses, and the kind of exposure he's had for various aspects of his training. It will also depend on his family background, his financial status with family. He has to have those at the back of his mind when deciding what he would like to do, whether he thinks of comprehensive practice, ophthalmology practice, or whether he wants to practice a subspecialty, where he's going to settle down, and what will be the course of life that he plans to take. So comprehensive ophthalmology practice is one of the important choices, and it has the advantage of starting earlier, dealing with a number of variety of pathology, and can be practiced in all kinds of settings. So essentially it boils down to whether to specialize further, whether to go in for a fellowship or not. Let's look at the other options as well. There are these senior residencies that are available in private institutions, government institutions. Some are excellent, some are not so good. Then we have the fellowships in India, we have the qualification examinations that are available. We have charitable institutions which are used as a valuable training ground for surgery by many, and then of course the options of going abroad for training. We don't have a survey from India, but in US, 2/3 of the residents plan to apply for a fellowship most often. Charitable institutions, as I said, hands-on experience is useful, and many opt for it as it gives them a base in the city or area where they want to work. Abroad, we know about the options in UK. The PLAB is a major obstacle, but that can be overcome by one of those exams like FRC Glasgow or Edinburgh. And then US, you have either the route of going through the residency after MLE, or you can go in for international ophthalmology fellowships, short term, long term. There are ways of getting over it, which I'm sure is going to be discussed in the later talk. Then there are the exams. We have the FRC OFF, which is also now available in the country. FRC is Edinburgh, Glasgow, Fellowship of the ICO, and Fellowship of the Collegium of the Ophthalmological Society. Well, Glasgow or Edinburgh examination provide mainly the help in forms of GMC clearance and practicing in some countries or enhanced emoluments in several countries, but there is no entry to specialist training. The FRC or exam, in addition, is recognized for specialist training in UK, but then it doesn't automatically do so. You still have to go through the process of GMC, and being in the institutions there takes some effort. ICU examinations are the only worldwide specialty medical examinations in any specialty held in 85 countries. So they were a really great thing, but I don't know the future of these with the future of ICO being in difficulties. Now the FICO subspecialties, we know about the FICO program, the FICO exams that are held. We have detailed curriculum now. These have been revised in 2022 and are available on the website. We had a detailed structure. We had subspecialty boards which did really work. They gave their recommendations on all aspects which we spoke about, and they were then vetted by other experts, and then they were sent to general body of AIOS. And the first attempt, second time they were revised by another panel of experts in 22, and they are available on our website. So the fellowship is one aspect I think which has been already dealt with, but I'll just stress that choosing the right institution for right subspecialty is important. Your specialty choice will also depend on what your objectives are, which specialty interests you, what is the demand of the specialty and financial potential. And then again, what your objectives are, where you're going to work, and how you're going to settle down, what your backgrounds, your strengths, weaknesses are. And again, personality types. You feel skilled at surgery. What is your personality type? And do you want to do private work? Do you want to work in institutions? Do you want to do more research? So you need to know what the demand for different subspecialties is. This is data from UK. We don't have figures of what choices are available or what jobs are available. Financial potential, again, no Indian data, but earning is as is listed here. So if that interests you. So in the end, I would summarize it by saying that you have to get to know yourself, what you want, what your background is, what your future objectives are. Make sure whatever resources you have, particularly in terms of your contacts with people and other resources, use them adequately, be flexible in your choices. Explore all options. Don't close any doors without thinking. Think of where you would like to be in 5 years' time, and think of a life and life balance with career balance. I think that is something we didn't do particularly well, but the younger generation is doing better. Thank you very much.
Thank you, Dr. Ashok. While Dr. Radhika gets connected for the next presentation, Dr. Santosh, you have something to add.
I was just mentioning about
Mike.
Some of the universities recognizing fellowships, especially Rajiv Gandhi University of Health Sciences in Karnataka, is a recognized fellowship. So universities award recognized fellowship, which is obviously not recognized by NLC, but that adds a layer of authenticity to the subspecialty training that we have. Otherwise, NMC doesn't.
Do it. FICO should do it.
Yes, but FICO doesn't have the standing in the sense that you cannot defend FICO in the court of law.
Once you develop that,
Yeah.
that's certain strength.
Right. We should
But
know.
then that forms the basis for placement.
Right. So we have the curriculum also already in place in the AIOS. We have to get the accreditation in.
So we go on to our next speaker, Dr. Radhika Natarajan, who heads the, I may not be very right in the exactly specific part of cornea. Cornea and refractive surgery, and heads the Department of Teaching and Training at Shankar Mekhalia, and I've had the experience of seeing how she conducted a wonderful conference, and I know what her skill sets are. But she's going to tell us something more. She's going to tell us about whether crossing borders for a continued education has relevance today or not.
Morning.
Thanks.
Thanks to ARC and the dynamic duo Dr. Chitra and Chitra for having me over here. So Dr. Chitra has asked me to talk on crossing the borders in cornea fellowship. I confess that I'm going to talk to you not about facts and figures, but my personal experience interacting with fellows in the last 25 years. The first border that the fellow has to cross is from textbook knowledge to the clinical connection. This is not a clinical talk, but clinical examples are the ones that we understand the best. So a fellow came to me with this patient who has corneal edema, and she was excited about discussing angioplasty options for this patient, DMEC, DSEC, etc. But if you stop and see, this is an FAT eye with a band of corneal edema at the large ICC section. This is just Brown-McLean syndrome. It's never going to progress, and the single-eye patient need not receive a transplant at all. So, the point that I'm trying to make is the textbook knowledge. We have to gently nudge them into translating it into clinical relevance, which is all about practice in later life. And this has to be done over multiple casual interactions over the outpatient. They're not PT students anymore, so this has to be an interaction rather than a formal teaching. And it is definitely a mutual benefit because we go all over it again and we revise our lessons learned in the past as well. So the next border to be transited is from supervised clinical interaction to independent patient management. And I, for one, stress on them that this is best started by documenting each and every case properly. So if you start from history and symptoms and signs and so on, and you either write it down or put it down, type it down in the EMR, then you don't have any gaps, you don't miss anything in the follow-up of the patient. For example, this again is a clinical example where the patient was thought by the fellow to have keratoconus. You can see the thin cornea over there. That's because she had missed looking at the patient from the external examination point of view. And there you can see the blue sclera. So this is in fact a brittle cornea syndrome. So putting it down in the proper order helps the fellow to understand the entire case rather than having an adrenaline rush at the actual diagnosis. And equal importance should be taught to them on reviewing the patient. It is not about that rare diagnosis or that surgery that you advise, but it is about completing the treatment of the patient or what they came for. So every review has to be done by themselves and not handed over to the colleagues, and they must be taught to emphasize subspecialty care as well. So glaucoma, the retina, how to interact with them and how to bring about holistic care is also something that they learn observing all of us. The most important barrier that they will cross is their surgical training completion. So we suggest a watch and then do and then teach another kind of approach from the junior to the senior level in fellowship. While there are a number of YouTube videos available, nothing substitutes they're assisting you, they're watching you when you're doing the surgery. And I, for one, have a practice where I see the fellow before they do their independent case and go over the plan either by dummy hand movements or by a diagram like this. This is what a fellow has shown me as what she could do during the tertium surgery. So there they miss out small points that you have to look at the medial rectus muscle before cutting the pterygium. So when they have a flow chart like this pictorially, then they know what step they should not miss. And of course, we can have an evaluation from the videos or by discussion after the procedure as well. And they must also be taught that it is not just what you do under the operating microscope. Equally or more important are the decision making which comes prior and the follow-up of the patient that comes later, because that goes to complete the surgical process. This is especially important in the context of refractive surgery because these are fully sighted patients and we cannot give them too much of hands-on to do. So the complete circuit of decision to surgery to complication management to follow-up is what completes the surgical care of the patient, which should be inculcated in them. And an important part of a fellow's life is presentations and publications. And what I suggest to them is that they document all that they do and all that they see. This way, they have a repertoire of data, and when they collect it and keep it, they don't have to scramble towards a deadline when they have to attend a meeting or something. They already have clinical or research information, which can then elegantly be put together as an abstract rather than do some hodgepodge last-minute preparation. And as far as publications are concerned, we have to involve them every time when we do something. It could be simple data collection or even references collating so that they watch and know what to do. And then later we assist them or mentor them when they have to do a publication. And finally, when they see their name in print, it is an exhilarating experience both for the fellow as well as for the mentor. I love it to see their names much more than I would see my name myself. So this is a short clip I put together. These give them a mind of their own and we need to listen to them rather than imposing what we want for them.
This 4 months of your training now. Why did you choose Shankar Vidyalaya to pursue your cornea fellowship program?
Shankar Vidyalaya offers a comprehensive cornea fellowship along with refractive and ocular subject exposure. and the fellowship offers a
So
good
basically, I think we are short of time. So here we have a junior, middle level, and a senior fellow. And the clip I will play for somebody who's interested later showcases the change in the aspiration as they climb up the fellowship ladder. So this perspective also changes as they go along. But as clinicians, we know that it is not just about clinics and surgery. It is about the confidence that we inspire in the patient, and that is sadly not inculcated in most programs. It's something that they watch and learn. So we need to impress upon them the soft skills, because it is not necessarily the patient in whom we've diagnosed correctly or the patient whom we've surgically excellently managed that's the happiest patient, and we know that out of practice. So that is something that we must play a role model and inculcate in them also. And the sense of responsibility, especially when something goes wrong, not to palm it off or not to deflect it back. It is in fact not the problem, but the way you address the problem that stays in the mind of the patient, which we should also make them understand. And Professor Grover touched on it right now, that common sense cannot be undervalued, and it should form the bottom line of all training during the fellowship. Here again, to quote a clinical example, a fellow brought a case of what she thought was herpetic keratouveitis. You can see the cornea studded with KPs. But if you go in and see, there is a fraudulent cataract. And where do you get cataract in herpes like this? It was in fact a lens-lytic uveitis. So, looking at things and lateral thinking is something that should be inculcated. And finally, these are impressionable young people. They will have their discussion. So, they should be time and again brought back on course, and the sense of purpose has to be inculcated so that they don't waste any bit of the 2 years. That is the bridge from their studentship to their career. The final frontier that they have to conquer is passing out of the program. Some people are just happy doing the tests and getting the certification, while some more ambitious ones do the prize exams. We are equally happy, putting together the quizzes for them. And finally, when they go out, they are full-fledged professionals. They unbox their skills to the outer patient world, but they never truly go away, do they? They form a community and blend into the alumni, the SN alumni in our case. And we always share with them our ideas, our cases, our patients, and they always seek advice from us. And the umbilical cord seldom gets broken. That is all very well for both groups of patients put together. Tracks back to the patient's benefit. Thank you so very much.
Thank you. Thanks a lot, Dr. Anita.
Thank you so much, ma'am. I just wanted to ask a question, ma'am. In all these fellowship or the comprehensive ophthalmology types, we have the basic clinical knowledge and basic surgical skills. But if they have a nucleus drop or a PCR, how many of these fellows or students are actually trained to handle such kind of complications on their own confidently?
So there are two answers to this question, Anaga. So it's easy way is to look back and see how you learn these things. That can form a mirror to how you can teach them. So during the surgical training, I feel the fellows should be asked to scrub up with the surgeon every time, along with the sister. Unfortunately, doing retroscopy or doing the nursing assisting is kind of waning. The trainees don't do it at all. If they do it for every single case, then they are able to see it when it happens upfront, and they can learn a lesson. Today, even if I have a complication, I think back as to what my mentor did at that point in time. May not be the same thing that I'm doing, but they generally give me a guidance as to how to do it. Post fellowship, somebody was talking about refresher courses. Yes, nice on paper, it's very nice to come up with. It's very laborious as an organizer. You know how difficult it is to do. That is where I feel this alumni community helps. It takes as simple a thing as a WhatsApp group. They have a problem, they post it over there. I have an idea, I post it over there. We are peers now. So each one gives their input, not necessarily the best every time. So the complication management becomes much easier when I take inputs from everybody or when they take inputs from members.
So that is why when you look at YouTube videos, it's easy to understand, but actual hands-on, because they are already in an institute, they are already undergoing a training program. So at least in such training programs towards the end, not just scrubbing up, but do they get to handle it on their own, independently?
So when they have a complication,
They are there.
The confidence and the expertise of the fellow, quite often they are able to do it to a certain level when somebody is there in the background. So on a case-to-case basis, not as a complication means I jump in. Who said I'm the best in handling complication? I may not do, sir. The fellow may be better. So to the extent possible that they can handle, it is best that we observe them and chip in if you feel that your expertise is going to make a difference.
Thank you,
Dr. Saurabh, Dr. Radhika was stating that beyond fellowship, the alumni groups and all helps you to stay connected. But beyond fellowship, do you feel that everybody should go for a short observership course or instead of a further fellowship? And what could be the duration? Or should it be that there should be a time gap and they are into their practice and then they take off and go? Does it have any relevance at all?
Yeah, I think as I previously said, that as a norm, every year I visit at least one institute or private practice 1 week in a year. So everyone can set their own time. So the idea is to cover the weaknesses that you find in your practice.
I will add one last point here,
Yeah.
expense of privilege of time. But that said, that is a very interesting and important point.
Yes.
But that said, I always emphasize to my fellow that you always perceive the grass beginner on the other side. You exhaust and you check whether you've exhausted whatever resources have been provided to you.
Yes.
These are on limited time. They're not going to come back to you again. You feel that this fellowship doesn't have this thing and that thing. But if it has 3 or 4 things that you've done under, please finish it up before you go outside. Look within yourself before you step.
Yes, very good.
Thank you so much.
Thank you so much, Dr. Radhika. You can see the passion, and I'm sure you must be a great teacher for your students. Yeah, very good points.
From you, it's like something to receive.
We go on to
We need to really publish, not how to publish. This is a tradition that has been established just about 358 years ago. Otherwise, there was nothing called scientific publication earlier. This was the first editor, Henry Oldenburg, who was the editor of a journal called Philosophical Transactions of the Royal Society of London. That is the first editor, and he originated scientific publications. In medical publications, in ophthalmology, we have the first journal that was Transactions of the Ophthalmological Society of United Kingdom as the English Ophthalmological Journal, which continues today as I, the editor of which currently is Shobha Siropisar. Now, in 1990s, we had scientists whose major goal was to find an explanation for a phenomenon. That is where their goal ended. They never bothered much about publication. They talked about it, and then it got percolated over a period of time by a word of mouth. Whereas in 2000s, we have an academic, where academics are goal-oriented and they want to get the results that they can publish in a good journal. The higher the better. So the concept of publish and perish somehow percolated into academics in any sphere of science and also in medicine, where the goal was to publish or perish. In fact, it was a compulsion, it still is a compulsion in several academic institutes and universities, where if you don't publish a certain number of articles, then you don't get promotion. In institutes, it could be financial disincentive or financial incentive. So when that drives publication, then it becomes a pressure. But when you take pressure off publications and publish for pleasure, then possibly you can change the term to publish and flourish, not publish and perish. So that's all it is about. If you enjoy publication, if you enjoy publishing, then you do it, and that will add to everything else that you do. Why do you really need to publish? When you look at the definition of research, it says systematic investigation including development, testing and evaluation designed to develop and contribute knowledge by dissemination of information. So that's a part of research. Dissemination of information is a part of research. Otherwise, your research is funded by somebody. It could be funded by you, your institute, the government, the public, and you are bound to publish it or disseminate that information that you have gained out of the research that you have done using somebody else's money or your own money for the time. Now, how do we disseminate information? Like the lecture I am giving now. Now, how many are there in this hall? 10, and maybe they are recording. Arup will put it on YouTube. But some will see that as lecture, but that doesn't give you the authenticity. We can have blogs, we can have non-peer-reviewed publications such as a city journal or a state journal. You can write books, but then the gold standard is a journal, which is a peer-reviewed journal. Except every dog has a blog. There are a lot of blogs. You don't actually go into each blog and look at what somebody has written, although Google search can give you some of these, pull up some of these. So peer-reviewed publications are the gold standard of academic publication. There is no doubt at all. They are at the top of the pyramid. Now, why publish at all? Because during the process of publication, you learn a lot. In fact, you read a lot and know everything about the article that you're publishing before you even start writing it. So you learn a lot in the process. You validate your own research and it brings accountability or credibility to your research. You create new knowledge and share and teach new knowledge. So these are all some of the positive aspects of publication. It also helps build science brick by brick. Otherwise, science is fundamentally a cumulative enterprise. So somebody discovers something and somebody else adds on to it. So over a period of time, it gets built brick by brick. And unless you stop building science, it stops at a particular level. So you actually help building science and knowledge by publication. It's said that each new discovery plays a role in one more brick to build the structure. For a starter or somebody who is just beginning into academics, what are the advantages of publication? It builds a stronger CV. If you are an applicant for a fellowship and there are two candidates who have scored almost equally well in the theory exam or done equally well in an interview, what differentiates them is the number of publications he or she may have. If somebody has 5 or 6 publications already versus somebody who has none, then that candidate stands a better chance of getting into fellowship than the other. So that's helping build a CV and also, of course, getting into a better job. In academic institutes, there are criteria by which they select a potential faculty, and this could be one of the criteria. Career advancement for somebody who's in a government job, it could be a way to advance in career, get promotions. In some organizations and institutes, there is financial incentive to publication. The higher the number of publications you have in a particular quarter, you get financial incentive. That could be one more reason. Awards, of course, research grants, professional growth, and academic leadership. So what do authors say? When you survey hundreds of authors who have published a lot, what do they say? Why do they really need to publish? The bottom line is that it makes them happy. That's what everybody says. But they also say that it improves their writing skill overall. It brings them a kind of satisfaction because people start appreciating what they read your publication when they meet you in a conference, they talk about it, they say, okay, you have written a good article, recently I read about it. It gives them publicity to their work. If somebody is doing work on, say, retinitis pigmentosa in a kind of silo, and if he publishes it, it gives a kind of publicity to whatever he or she may be doing. It adds value, it keeps them alive as a researcher, it motivates others to do research, and gives others or externally to access their work. But finally, all said and done, what does it give you? It gives you academic immortality. Books will be forgotten, books may go out of the library, books will go out of the nation, books may not be available on Google, but if you write and publish, if it's a peer-reviewed journal, it always forever resides in PubMed, hopefully, or some other source in internet, and it gives you academic immortality after you have gone. After 50 years, 60 years, if somebody pulls up an article that's written by you, they may recognize that, okay, there was somebody of this sort who gave some knowledge. So that's kind of academic immortality. Of course, it opens many other doors. Well, academic worth of publications is also something that you need to consider. There are author matrices. H index is simply good. If you have 50 publications, each of which has 50 citations, your H index is 50. Or if you have 100 publications, out of which 50 publications or 50 citations, your H index is 50. That's one of the measures of author's value. There is I10 index, which is nothing but the number of publications of an author that have been cited at least 10 times. And if you want to know your authorship value, then you simply establish an account on Google Scholar. It would have already archived all your publications and you really know your H index and I10 index immediately. So you can actually know your authorship value with that. So finally, this is my concluding slide. The purpose of writing is both to keep up with life and run ahead of it. That's what was said. Publication is an integral part of academic life and is vital to the growth of science and career progression. There should be healthy thirst for research and publications, but nothing unhealthy, nothing that would make you extremely or unethically competitive. Peer-reviewed journals are the gold standard for publications. Citable publications increase your personal academic worth, which are measured by H index and I10 index. It should not be punitive but contributory to progress. So final word should be that you should publish and flourish, and it should be for pleasure, not pleasure. Thanks.
Dr. Santosh, as usual, it was an excellent talk. I just wanted to ask you, how can we enhance this into the curriculum of the students so that it becomes more critical that more and more of them come into publications? And what is the deterrent for that? And again, the second question, which I also wanted to answer after that is, we do know that we are, I know your numbers have gone up about receiving publications, but still, having said that, there are many of these publications which come to you where you really have to sit and change the whole format to make it presentable. So, what are your thoughts? How can you improve it that more private practitioners, more people in practices can come forth because they have a lot of clinical material with them?
So the first question is that in fact in many of the universities publishing an article has become a mandatory thing before they give their MS exam. So that actually compels a student or a resident to write. That's one thing, that's something that is good. So when there is such a compulsion, there is always a scope for training them to write better, which would become part of the curriculum. Right now it is not. Second thing is that we actually, as an editorial board, we rewrite many articles. It is never in a form that it is initially submitted. There is peer review process beyond which you have to actually sit and make this better.
So how do you do it?
For private practitioners, we have two more formats. One is case report format. If they are busy private practitioners cannot put together an original research article, they can simply select out cases, the best of cases that they have seen, and write a short report and submit. There are photo essays and ophthalmic images as well. And for those who really cannot write, they can make a good video, add commentary and submit. 8-minute video which are already on format, AIOS videos. So there are many formats to publish, not just written article.
Dr. Saurabh or Dr. Girish, your thoughts? Because somehow suddenly we have time in our hands. And we have only 2 speakers left. And I don't want to lose out on e-learning to having some of our audience today.
One question to all the, I think, now sir, Dr. Girish sir, Dr. Madam, we get DMB students or MS students who are supposed to do the thesis, but they have very short time in hand. Sometimes they have just 2 years to finish up the thesis and then submit and get published also. Many times we find difficulty finding good topics, like new topics. Many times we find that many students across the country are doing similar topics and publishing similar things. Anything we can do to improve that, or to give us suggestions on newer topics to entire community so that they can use it?
Yeah, my thoughts are that if you have a journal club as a part of your academic activity, every 4 articles, discussed right there, that will give you a lot of research articles. Not to copy those articles, but the way this research has been put together, there might be certain criticism that are raised in the journal club, that will give you a research idea.
Dr. Girish has given the mic to me because I've been a DMB assessor from the mentor for the last many years. So the way I look at things is, not to go for the timeline or the deadline at all. It may be a case report, it may be a thesis, it may be a conference presentation for the fellows. Better to have a repository of ideas, cases, projects, and keep the work going at a good pace, and then fit it to the requirement of a presentation or a thesis as and when it comes, rather than scramble towards the deadline and do it the other way around. That way, like Dr. Honavar pointed out, we can do it for the pleasure of doing. Normally, that's a difficult attitude to come by for the PGs because they're not experienced in that direction. So it's up to us to nudge them. Like I was telling him, when the fellow has a posting with me, I give them a goal of 1 independent surgery minimum, 1 class presentation, and 1 case report by the end of the posting. So we have the whole 4 weeks or 8 weeks to do that. And then tomorrow, when there is a deadline for a conference, they already have material ready rather than rushing up to finish something. The same can be applied to the DNP thesis scenario as well.
Sir, wanted to ask you one question. In case of people who go on into private practice and after a few years, they get so busy in their own private practice that even though they wish to publish, many times, like you said, for an original research article, case reports, yes, definitely they can. But if they have intention of doing an original research article, many times the feeling is it takes too long and somewhere down the line you start, but then you just give up on the way. So, what is your guideline or recommendation as to how to keep it up and how to follow, what regimen to follow, so that, or is there some like mentor kind of thing in this?
So we have short-term programs. We have actually journal conducts short-term programs.
Yes.
Mike, please.
AIOS actually conducts online courses, publication workshops, right? So that is just a day-long workshop that will reorient anybody to that. Most important, I think, is to keep documenting and archiving a series of views. If you're on EMR, it is good. Otherwise, you have to have a habit of having an Excel sheet in your own practice where you keep on entering a particular, number of whatever good cases that you have seen or kind of series that you want to really make, so that you can pull it out. If you don't document, you don't know information as to how you put together.
Thank you, Santosh. That was a guest discussion.
What do you think are the challenges of AI chat for you?
AI chat GPT, well, I mean, they will pull up information from the internet and you will be able to possibly get a lot of assistance in writing. But that is not real research. It is very difficult. AI is something that we have to live with, but that will also bring some analytical practices into writing. There was a recent submission where an author had put ChatGPT as a co-author. So what do you do with that? Yeah, ChatGPT is this first co-author. Author's name and ChatGPT. We got an article for publication because he had used ChatGPT to format information. These are some of the questions that we have to ask.
How to curb it, how to overcome it, how to.
He was truthful because he has seen ChatGPT and he has admitted it. You cannot overcome it. You have to live with it and find solutions to it. It's a challenge.
Because it is so, within no time you get everything. You write a synopsis of it, write an article on this, you just type this, write an article on character and you get everything. Yes, you just type it here, you will get everything. And in a very authentic language, with all the references in it.
It's a machine language, but there are now software which will convert that machine language to human language with whatever errors that humans are supposed to make. So it is actually indistinguishable.
But I just wanted to know how we can bring the doctors in the periphery for the research and publication, because the generation has changed and newer generation fellowship trained persons have now gone into PhCs and CHCs in our country. They are into government job.
But they're actually writing now. If you want data, I can tell you the last 6 years, 2,412 new authors have been added to.
Yeah, that is true. But from the grassroots, means our so 25,000 ophthalmologists in our country. How many are doing this writing work? About 30%. So, because the newer generation is doing better, and they are fellowship trained, they are trained from good institute, they are now employed in the government sector. So, these government sector doctors, we can bring into the mainstream of publication.
They're coming in actually. That's what that data actually shows, that 70% of them are under 40 and 70% are women.
Yeah, but that is in ophthalmology entrance examination. You see almost 70% are women, or 60-70% are women in all the medical indica, all the colleges for this ophthalmology curriculum. That number is changed. The ratio has changed.
We go on to our next very eminent speaker, Dr. Suhas Halipurkar, who is the founder chairman of the Lakshmi Eye Institute based in Navi Mumbai, and also the chief trustee of the Lakshmi Charitable Trust. He is one of the foremost phaco surgeons of our country, and I'm sure he has trained numerous number of surgeons along the way. But however, he is going to be talking on something different: the best practice patterns for enhancing podium stature. And I think it is something very important for many of the young people to know.
Thank you, Dr. Chitra and the ARC for giving this talk. When I received this message, it took me some time to understand the topic. And then I went to do some search. When I Googled for podium stature, every time it would take me to the structure of the podium. It would tell me about the depth and the width and the height of it. But one thing I understood is that for a short person, if you want to be heard well, if you want the audience to know where the voice is coming from, you have to have something to stand upon. You know, there's another thing I learned there was that there are some etiquettes in how you stand behind the podium. You cannot be leaning on it. You can't be just moving this side or that side. You know, there's a distinct difference between the mannerisms when you're conversing and when you're speaking. And they are distinctly different. So you need to definitely cultivate those things. And then I just thought, let me go back to whatever I have known for a long time with regards to speaking. I remembered one very famous anecdote which most of you would know, that when a couple is sitting and the husband is called up to speak, as he's walking towards the podium, you know, his wife quickly slips in a small piece of paper in his hand, in which she has scribbled "kiss." That means keep it short and sweet. You know, it's very easy for us to go off track. Now just imagine, I'm asked to speak on a topic like PCR. And then I go and go through my archives and take out the best of my PCRs, and I'm sure at least I have a lot of them. And then you sit and prepare your talk, and you are standing to give your 8-minute talk on PCR. By the time you are done with most of your theoretical preparation that you have done, and you are actually coming to the meat of the talk, they say 7 minutes are over. You are only left with 1 minute. And then that 1 minute you have to literally hurry through. And the best part is always there. So that means I haven't really prepared my talk yet. So I remember a conversation I had with Dr. Chieka several years back when we were sharing a stage. And he said, "Doctor, do you know why when these American surgeons come here to speak, if they have a 10-minute talk, their talk gets over in 9 minutes and let's say 45 seconds. And if they are traveling from here to Delhi to Hyderabad to any place, on that topic, their talk is same. It doesn't change. And that's because he said they have prepared for that talk at least 25 times in front of the mirror to get it. Practice until you can't get it wrong. And that's what they do. And that's what I think, if you want your speech to be more effective, that's what we have to do. And like they say, Mark Twain says, there are 2 types of speakers. Either they are nervous or they are liars. And it's very true, because even the most celebrated speakers in the world, before they gave their, those immortal speeches, they always had some nervousness in them. And this is going to be part of anyone who stands here. And that's the reason you have to use your nervous thing to your advantage. How will you use it? That you will use to kind of give you an energy to perform your best. It is said that the human brain stops working at the moment you're born, starts working when you're born, and never stops until you stand in front of to speak in public. And we all are aware of that. There's something called brain fog. You just can't remember what you want to talk. To this, I would add something that I heard long back. It said that if I'm standing here to speak and I have prepared my talk on, let's say, a particular topic, at that moment, on that day, you have the best of the preparation on that topic compared to all of you sitting there. And so, I'm here to deliver a talk which is going to give you something to take back home. Now, if this kind of a thought comes into my mind, that gives me confidence and that makes my nerves calm down and I can deal with it better. So I think that is a practice which we should always be doing. Because these butterflies in the stomach are going to be there for all, it's very common. Why do we get them? It's our innate desire to be perfect when you're speaking. And secondly, we always have the fear of being judged. Now, what it means is we are all the time focused on our own emotions when you're standing there to speak. But your audience should be your focus. Now, if I shift my focus, I just have to ask myself, do I want my audience to get inspired from whatever I'm going to tell them? Do I want my audience to carry back some message, something that can be of help to them? Or do I want my audience, let's say I'm talking about some surgical technique, do I want them to use that technique? Do you think, if you think it's a good technique, everyone should use it in their practice, or some protocol that I have which I feel, if that kind of focus I have in my talk, then it naturally makes my talk more fluent, it makes me more effective. It is always said when you speak, look at the audience. Now, if I look at one person all the time, it kind of makes it very uncomfortable. And I can't be looking somewhere there or somewhere this. Like I can literally scan everyone, maybe spend a few seconds with them. You know what it does? It kind of connects. And that connection is something really good. It has a lot of other meanings. It also talks about the kind of confidence with which you are talking. It's a yardstick. So, another thing, if I'm given a talk, they can have multiple things that I want to say, but I have to have something, and let's not have too many things that I want to pack into one talk. Just be focused on that one. And sometimes it will go off the track. Always try to come back to that, because that is what we want to deliver. Another thing, like there are people who are by default fast, like they speak around 160 words per minute. There are some who are very slow, like I speak slow, maybe I use 120 words. But for you to be more effective, let's say 140 words per minute, it is a kind of speed that one should practice. And like it is said, all these things need to be cultivated, and practice is the only way of it. And of course, when you have a lengthy talk, even if it's 8 minutes or 15 minutes, you should always at the end summarize it and tell them this is what you take back home. Because so that's the only thing the audience will remember. So in nutshell, there is no shortcut in practice. Nerves will always be there, use it to your better advantage. Before you start your preparation, you should know what your audience wants, deliver what they want, not what you know over your feet. Speak slow and in between, taking out those pauses, really like in music, have the pause that gives a beautiful music. Even in a talk, if you have the right pause at the right time, it makes us more effective. And of course, helping, connecting with your audience. So these are the few things I thought I would share.
Wonderful talk. As nothing less was expected.
Oh, really?
Yeah. And I wanted the expert panel, Dr. Girish, Dr. Saurabh, Dr. Purendra Singh, your thoughts on that. Do you think that we have to ensure the curriculum? I think again Radhika is going to answer this. How do you ensure in the curriculum that the presentations are made of top quality, and how do you keep reiterating to it? He has told us in nutshell most of what is to be said, but how do you take care of your fellows, how to give the best presentation, and how are you critical about it?
As Dr. Santosh is saying, you have such a clinical program in the institute, whether it's General Club, these presentations or didactic lectures. I think that those are a very good platform for fellows, and since they are practicing a huge faculty as well as residents, that's one of the best ways to all this. And in our institute, we also recommend anyone who is presenting at conferences, especially residents or the doctors, need to first present it in front of the department and the faculty. So that,
Yeah, I guess that kind of summarizes it. What I do with my fellows, if they are presenting a paper which I have mentored, is we go over it again and again for multiple reasons. One is to speak to the content and time. Like Dr. Suhas pointed out, by the time they come to the important part, the audience's attention span is lost. So to stick to the important parts, and while speaking, I tell them don't talk to yourself, talk to the audience. The best of content may get masked because of improper or very diffident kind of presentation. Sometimes I do a little bit of role play also. Not that my model is the best or anything, but we've come this far. So there must be something in it. So I do the presentation for them and let them listen to it, and then they take the point that they feel are important. The modulation, the content presentation, and how to grab the attention of the audience. Even 30% if they can take from to 70%, they can build up this. We go over it again and again and again till everybody is happy. Till we can't get it wrong in some ways.
Yes.
Also the timing, like Sir said, many times they overshoot the time incessantly and it becomes really irritating for the next speakers and when they are presenting in other conferences. So the importance of
I think one more thing is that we have to maintain the continuity, the flow of the session or the talk or the previous speaker where in that session they have spoken into, and you have to connect it and make a flow of it, and you have to modify your talk accordingly in between. You have to change it. If someone has already spoken to it, if you don't emphasize on that part and emphasize on the rest of the things which is important, and to be in the session right from the beginning, that is important because otherwise you are not aware of what previous speaker has said.
So they need to be attentive to
and you have to make a flow, there should be a flow in the talk, and with which things should improve with time. That is what is very, very crucial. But wonderful talk, I should say, Dr.
Yes.
Suhas given us the best of it.
We need to give a special
Yeah.
and Dr. Ramurthy
Can I suggest a comment? I think however seasoned you are, you cannot be able to speak at all for it. It varies. I think what dictates your presentation is what Dr. has said, the judging people with the audience. So if you ask me, I think all my in-house meetings, I'm always worried because the entire hospital is judging you. The same way, I think international preparation will be different from a small. I think nobody can be a consistently good speaker in all meetings.
Thank you so much.
Yeah, we go on to our last speaker of the session. I think this needs to go on record that we are finishing before time. So I would really want a lot of discussion so that lot more is gained from it all. And we have Dr. Ramurthy, who is the chairman of the AI Foundation and our past president. And he is going to talk on a very important topic, the need to stay involved, why it's critical.
Thank you so much, Chitra and AIOS, for this wonderful opportunity. I know a string of superb speakers have spoken before me. Unfortunately, because of some clash of sessions, I could not be present earlier. Let me just try to take you through my thoughts on what I stand for and what the way I have progressed during my professional career. These are the brands that we grew up with: Kodak, Nokia, BlackBerry. These are things that were in everyday use. We did not know the word photostat. What we are using is Xerox. But none of these companies are existing today. None of them they have either been taken over or they become a very small part of some other huge conglomerate. 80% of the Fortune 500 firms that existed in 1965 are gone today. They're either bankrupt, they're merged, or existing but in a much smaller profile. And funnily enough, we all feel that family professions they tend to go on and on. only 30% of family business make it to the second generation, and only 13% make it to the third. Somewhere along the line, they lose their focus, they become irrelevant. So that's the reason that irrespective of whether you look at large practices, large conglomerates, multinationals, many of them over a certain period of being right at the top continue to shrink. And one of the greatest challenges that we have today is to future-proof our business so that what we have done over a period of decades continues to sustain and the next generation is able to take over. This is something that I have held very close to my heart, and this has helped me well right through my practice. All these young ladies in front look quite nice, but the one who is going to you're going to remember in this photograph is the lady at the back, simply because she looks different. And it was Aristotle Onassis whose claim to fame lies not just in the fact that he was married to Mrs. Kennedy, but a very successful tycoon. He said the secret of business is to know something that nobody else knows. So when I started off in my practice way back in a small town of Coimbatore, just getting a fluorescein angiography and a laser machine, call for a cerebration, call for an exposure. That's actually the deputy chief minister of that time who came to inaugurate this. Today you will find this in every street corner, but that point of time, because you have to go to either Chennai or to Madurai for getting your laser treatment done, just having this instrument did differentiate my practice. And then of course, even a yak laser installation called for a celebration. And I think this was one of the greatest turning points of my professional career. When we went for a LASIK installation in 1997, it was costing $500,000 then, and for a 2 people practice to go in for this kind of investment was something that was unheard of. And that was exactly the year when Arvind Eye Hospital opened up in Coimbatore, and we thought they very suggested this time for you to close your practice and leave town. But the fact that we had something to offer that our peers did not have helped us to differentiate. And it's not that it's once you do something and that sustains you right through your career. You have to keep inventing and reinventing yourself. And today, very recently, we have gone ahead and acquired a mobile femtosecond laser platform, which we are able to shift around in 6 different centers, offering laser cataract surgery as well as something like the spine platform to these patients. So one of the greatest things that I lead, it's not just a monetary success that you count by, whether it is your postgraduates, your fellows. You have to be drive home the fact there has to be a relentless urge to grow. Just if you are satisfied with what you have achieved, then the passion for growth dies, and eventually you yourself will become irrelevant. As I said earlier, as you go along, it is not just one event or one of the particular equipment or one particular center that makes a difference, but it's a gradual growth. But it's not, in my case, it has been building hospitals apart from education and presentations, etc. But this could be the number of papers that you have presented, the number of awards that you have won, the kind of recognition that you accrue as you go along in your professional career. Cataract surgery is the commonest surgery that I perform. And this is what is the yardstick I measured my cataract outcomes in way back in 2006. One good, thanks to my grounding in Chankanethalaya and the RP Center, I always had this practice of looking back at my results. 2006, as far as I made patients got the 6/6 visual acuity with a correction, -2, -0.75, 1.25, it was a given that presbyopic CAD would come in. But this is, I was quite satisfied with this kind of results. But then when it came to 2015, we started focusing on optical biometry, better formulate. Basically, what we tried to achieve was a plano outcome as far as the cataract surgery was concerned for distance. But again, multifocals and torics were just coming in. And we basically thought that there's nothing wrong in allowing the patients to wear glasses for their near vision. Then today's world, as most of you would experience, this is what we are looking at. Not that each and every patient of mine gets a multifocal intraocular lens, but this is actual analysis of what we are doing on a day-to-day basis. And this is particularly a single-day surgery on 2006 to 2015 and 2021. I'm sure most of you are getting these results. Obviously, if I had stayed contented with my 6/6 best corrected visual acuity with a pair of glasses for all my patients, the kind of impact that we would have had in cataract surgery would not have been there. There's always a significant amount of research, market research, analysis which tells you why you cannot do something. Is often your gut feeling, is often what tells you that you will succeed and you take up the challenge and eventually succeed, eventually turn it around. This was a small hospital. It was actually a small clinic over here when we took over, over 250 square feet in the city and town of Tirupur, where I left Shankar with a lot of hesitation, went there and started my practice. Then slowly built it up. And because we had within 3 months of starting my practice, because I was told that nobody is going to travel from Coimbatore to Tirupur to get the laser treatment done. By that time, I laser, I mean retinal lasers. I established another 200 square feet clinic in Coimbatore. And slowly we went across, and today this is not all the centers, but we have multiple centers. And it is not just the need to earn money, need to become bigger or competing with somebody. It's just that we had a reasonably good pattern, good plan, and we could replicate it without any difficulty. There's no equity, there's no investment that we have brought in. It's all from personal accruals. It's a sense of satisfaction. It's not just our growth story, and it's not just that it happens only in big cities. You can see excellent examples dotted across the country. Barakpur, in Dehradun, in Chitrapur, one of the superb centers that you can come across. I think they do the world's highest volume of cataract surgeries as a single institution. Jorat, Udupi, etc. is essentially the relentless drive of the vision of the persons involved which leads them on to evolve and be continually at the top. I think very often it's the failings from which you learn, and I've always felt that something which doesn't work for me, I learn something from it and move away. This was the third center that we started in a nice place in Kerala, hardly about 150 kilometers away. A very nice multi-speciality hospital. We were asked to take over the eye department over there. We set it up, stayed there for 2 days. It was very difficult to get doctors there, patients there. The people were extremely nice, but it didn't work for us. So we moved away, cut our losses and moved away. But there was an invaluable lesson that I learned, in the sense that essentially a small eye department in a large multi-specialty hospital is not going to work for me. And that's a pattern I've stuck to till today. I think I still maintain excellent relationship with the corporates who established the hospital. We are good friends. We continue to maintain a good relationship. But I think there was an invaluable lesson that I learned. This might be the most important slide of my presentation. In the sense that if you just have to look around, looking at the cost of infrastructure, equipment, personnel, etc., there's always a certain amount of attraction to cut corners, to make deals. So obviously, if you look at the greatest of institutions that are around us, they have all done this by relentlessly pursuing a policy of honesty. You're constantly being observed by your family, by your spouse, by your children, by your employees, by your patients, and you have to lead by example. Just in case you're implanting the wrong type of intraocular lenses after charging for something else, you cannot fault with that OT attendant who feels nothing wrong in taking away a few intraocular lenses. I think it's most important that stay in the policy of honesty. I think in the long run, that's what is going to sustain you, and in the long run, that's what is going to pay off during a lifetime. It's also very important to understand as to what really is important, what is the kind of change that you require. Because every new development is not something that you need to adapt and integrate in your practice. This is the type of eco machines that I have in my practice today, cross centers. And just now I was in ACR, I just came back, and then I was particularly fascinated by a new phaco machine brought up by one of the multinationals who said that's the very best. That's something you need to have. You cannot survive with this. That's not Centurion, that's not Signature Pro. That's something that they are offering for the part of future. But obviously, this is not it's not necessary that just because the latest or the newest, you have to go ahead and adapt them. And ophthalmology is extremely equipment focused today, and you have to really understand that what is relevant to you, what's relevant to your practice, the size of your practice, the kind of population that you cater to. And sometimes the staying away from certain procedures have been what has been most made the greatest difference for me. Refractive surgery forms an integral part of my practice, and these are the certain procedures which I looked at very closely, but decided to stay away from them. I think that was a good decision. So just because you are evolving, doesn't mean you have to be the first person to adapt each and every technology. Wait for it to mature. Do not make it too late. But then once it seems to be acceptable, then go ahead and adapt. I think the other important thing is that it's not the equipment that we have, the infrastructure that we have, is the team that we have built that's most important to me. This photograph was taken about 15 years back, but today we have about 75 consultants, about 140 optometrists, a little more than 1,000 employees across the board. Basically, this is my challenge as well as my strength. The ability to make them see the vision of the particular organization, integrate themselves with the organization is most important. As far as each person sees a growth for himself or herself within the organization, willing to contribute, then that would be the way to go. I think customer delight, all of us know about it. It's not that just because you're a big name in the practice in the local area, you have a good flow of patients. It doesn't mean that it will sustain you forever. Whenever complacency sets in, then that's the time you tend to lose out to the competition. Customers won't give large orders if we can't handle small ones. Oftentimes there are occasions when a young patient is given a minus 1.5 diopters. The parents insist on seeing me and having a discussion about why this happened, as if that's the end of the world. I definitely take the time out to go ahead and talk to them, reassure them, tell them the ways and means to stabilize the power that the child has, take care of it after the age of 18, 20. Once I spend that time, then that's the parent who brings his father for his cataract surgery, his uncle for his retinal laser treatment, his daughter for his LASIK treatment. So establishing a relationship, addressing concerns of each and everyone who walks through the portals of the institution is extremely important, irrespective of the magnitude of the problem which they come. I think this is extremely important. Again, I keep repeating this all over. Value always comes at a certain amount of expense. The converse is not necessarily true. Just because you're spending a lot of money, that doesn't mean that you're going to get great value. So whether it is changing the roll on sofa, getting an excellent consultant at the right price, or modernizing your infrastructure, spending the right amount of money so that your infrastructure, your equipment, what you offer to the society at large is commensurate what they expect today is most important, and that's when you keep yourself involved. Moving with the times and updating yourself is extremely important. It's not just the infrastructures which is there which is necessary. We have a EMR, an ERP. I think most good institutions have it. Sitting in my chair, I can see what exactly is happening to each and every patient across my 19 different sectors. Have a control over what my staff is doing. Obviously, all of us have moved away from these huge racks of MRD files. It's what we have is a storage server, rack server. The larger the institution, the more critical it becomes important to adapt these technologies. And it's not just for the large institutions alone. Even a single practitioner, and when they adapt this, modernize the way they are treating their practice, then that's the hospital management system. Looking at the audience that is sitting here, these are things I'm sure each and every one of you, and I'm sure you acknowledge the fact that this has played an important role in your evolution of your particular organization. Security, CCTV cameras, recording, in spite of the fact that it comes at a considerable cost, these are necessary investment. Today, I have a particular person employed who sends me a report every day telling me whether all the CCTV cameras across all sectors are working. This we started about 6 months back because in a survey we found that almost 30% of the cameras were not functional and they are just let it be. So essentially nowadays we have even the system to monitor, not that you have installed equipment or instruments, but also to make sure that they are also functioning in the appropriate manner. COVID, as we all acknowledge, has been a great teacher in many ways. Previously, this is what we had, where we had to physically meet to interact with each other. Today it is not clinical presentations across the globe, but within the organization also. But even as far as the review of performance is concerned, there's hardly a need to travel to each and every institution, but you can have a effective, meaningful, timely conversation with the people involved, whether it's clinical or it's just administrative. I think this is the final slide of mine, and this is what I've always lived by. I have in Coimbatore, if you throw a stone, invariably we return off the notice. We were within the 100 feet of us, we are surrounded by good hospitals performing extremely well, and I have no control over what they do, what equipment they bring in, what kind of faculty they have. Basically, what I look at is that year on year, day on day, my performance should improve, whether it's in the publications, whether it's the way my opticals is performing, the number of LASIK procedures that we do, or the number of VR surgeries or number of consultants we have. As far as that urge to grow on a day to day is there, you try to evolve, do better than what you did last year, I think you will have a reasonably successful practice. Change is tough, but that's essential, and if you do not change, it's obsolescence that you will face, as you saw in the very first slide. Thank you so much for your time.
Thank you very much, Dr. Ramurthy. That was again a wonderful talk and definitely energized all of us that how we need to stay involved. Any
Can I ask a question? Excellent talk, sir. And definitely, I think it's like, life is like a treadmill and you need to keep running just to be in the same place. And really, it takes so much of grit and determination at every point to not only just intend to grow but put in all those efforts. So, you mentioned about that one place where you had to cut your losses and then get out of that situation. Many times, when if it were your own kind of center, not with a multi-speciality, how much time would you actually give that kind of center, and what would you do? It's like your a sore thumb where you would give a little more care to it. So, what extra effort would you have put in, and waited how long before you could actually move out of it?
Fortunately, I have not had to move to any center of our own which we established, and definitely it takes time. There's a lot of handholding, nurturing that you need to do. Once you have set up a system and the faculty there, the staff there are well settled down, when you start a new center, depending upon the location, the kind of infrastructure, the kind of investment that you make, you have to be patient. Thankfully, as far as ophthalmology is concerned, the vocal component of the hospital is not there. Most often, the centers try to break even, at least on the day-to-day expenditure, within a matter of 3 months to 6 months. But having said that, for them to ramp up their performance, I think it's extremely variable. And it's not the equipment or the infrastructure which makes a difference. I always feel it's the key doctor who are there, the key professionals who are there, the kind of administrative people who are there who make a difference. So there have been centers of mine which have taken even 3 or 4 years to perform to a level in which we expect. And the more metropolitan, the larger the city that we come to, the longer the gestation period. The smaller places you go to, the success of that seems to be much more. I would not really have a specific answer to your question that I'll wait for 1 year and then withdraw. As far as I find that the growth is there, the team is motivated, I'll give it long enough for it to sustain and grow.
And another question was, sir, you have a large team, and I think when you start initially with a small team, it's more like a mom and pop kind of family, but here it is much beyond. How do you actually, these Zoom meetings definitely help, but how do you manage and ensure to connect to each and every person and ensure that they are in line with your vision? Because I think until and unless they are aligned to your vision, them working for you in the best possible way becomes very difficult.
No, you're absolutely right. That's the greatest challenge. You want to live in a certain way. You want to treat your patients in a certain way. You want to keep your hospital clean in a certain manner. But getting this thought process percolate not just among the consultants, among your entire staff is the greatest challenge. Basically, now all these data that we have, all the different equipments that we have, we're able to, on a monthly basis, the only connect I have with my various centers is a monthly review meeting. So the key personnel over there are there, and then from the head office, the main persons are there and review the performance of the center for the entire month. Then obviously, if I go there every week and I'm handling them on a day-to-day basis, maybe they will perform a little better. Whereas the most important thing is they should have a sense of ownership. You have to empower them, set a trend, and tell them that this center belongs to you. Your growth, your progress depends on this. But just because the hospital is ramping up, instead of doing 50 surgeries, they start doing 200 surgeries. But the consultant who is performing these surgeries remains at the same level. He or she is not going to have any linkage. That applies not only to the doctors but across all employees. So when these say that the particular center is doing well, our growth, we also have a future in this. That's when they will start contributing. This is something I try to do.
It's very true. Surprisingly, all the speakers have spoken very well, and we still have pretty. Not surprisingly, I'm sorry. Incidentally, but we still have. Accident. We have 20 minutes in our hand. So instead of, so I would want one expert coming from all the expert panel here, Dr. Saurabh, Dr. Mahipal, Dr. Girish, and Dr. Purendra Basi, to give your thoughts as to how you stay involved. It cannot become a talk. You'll have to just say a few sentences how you stay involved. Yeah.
I really don't know the lot of reference in the context, but evolution is something that you have to understand that change is constant, and if you don't do a change, you're going to decay. So evolution, I think, getting younger blood is always a thing. Staying up to date by doing CME, talks, etc. Attending conferences is something important, and also looking critically at technology that's available. That is something that has to do, and I think growth is something which is very important, whether it is one center, whether it is 3 centers, 100 centers, that you have to keep on growing, because obviously there becomes a capacity constraint when you are looking at one particular location. So either you expand physically, or you put up new technology, etc. Evolution has to do with your mindset. You have to always be out of your comfort zone, and that you always tell me kya karna aur kuch karke. So that's something which is important. The fellows and the young blood and the new residents, etc., they also keep you, because they are really full of enthusiasm. They also have a lot of knowledge which they test, which you have, and what has to be done. And along with that, I think what is very, very important today is the managerial skills. That has become an integral part of any hospital management. You just can't be looking at it from an academic standpoint. Leave that things to the other people. You don't need to do the non-essential things that are there. And growth triggers, setting budgets or targets are also something which is very important. That this is what we want. You need to have a 5-year plan, I would like to say, where you want to be, say, 10 years ago, 10 years from now, what is your vision statement, etc. That has to be quality control. So that's, I really sorry I haven't heard the previous talks, but this is what I personally feel is how you want to keep it.
Thank you. Dr.
I think Sir has summarized most of it very well. I think what is very critical is for each one of us to know what is our strength, and then play to our strength, align that to our mission and philosophy. I think it's very important to keep it very simple. Do not have a 25-year or a 30-year plan, as Dr. Mahipal said. Have a 5-year plan and keep rebooting yourself based on what the market situation is. But not everyone's goal need be statistics based in terms of increasing numbers. It could just be a qualitative improvement also. So that's where I would see.
Can I ask a question? Just one question. How much does peer pressure actually have an impact on growth? Damayanti sir, how much does peer pressure actually have an impact on the thought process that you have? And this is for everyone.
Well, you you can't live in isolation. That's the thing. Peer pressure does have an important role. Often, the biggest thing is that once a new technology comes, somebody says he's got a new technology, he's sitting next to you, he'll take away all the patient and things like that. But I think you have to do your own one, and you have to really look at it from the whole perspective as to whether it is going to deliver or not. Peer pressure is something that needs to be there. I think it is always there. When you are running a race, whether you call it statistics or whatever it is, you know that this is the world record, say 100-meter dash, this is the world record, you need to do better than that. So I think there is always peer pressure which is there. And not just, it can be peer or it can be an overall segmentation of things that are happening. There's a lot of change that is happening in healthcare. I personally feel that there is so much of consolidation that is happening. You can look at right from where a care hospital getting sold or a KIMS being sold. So consolidation is going to put a lot of peer pressure. That is going to be a lot of money power that is going to come into healthcare, because healthcare is a long gestation period, and big pockets are going to put a lot of pressure, whether you call that peer pressure or whatever. But that's going to work, and that's what I feel, that it's like a treadmill. Even if you have to stay at the same place, you have to keep running. You just can't sit back and relax.
I think peer pressure is the most important motivator for growth. In case I was a lone cataract surgeon in a particular city, I started out with intracapsular cataract extraction. I would have stayed with it. There would have been no motivation for me to grow. The only reason I constantly explore different avenues and try to grow is because if I don't offer that, the society is going to have someone else offering it. I think it's extremely important. The greater the competition, the better is the growth. And at the same time, we have to be conscious of the fact that peer pressure should not impact you negatively. Make sure that the technology that you're adapting is not just because the other guy is having it, because it's mature and it's going to do well for your patients. I would just like to quote an example. The conductive keratoplasty came in, and at the age of, everyone said that 40, 45, refractive surgery was just going in. They said people are going to line up and get their treatment done. There's so many people, millions of people who are doing 40. I got this machine for 3 months just on for a trial basis. Tried it on a few patients. It was not working well. Whatever little effect it had, it regressed. But using me as an example, the same center, the same company had gone to another center which is close by to me. So this doctor has already got this. The queues of patients lining up for him. How can you survive without this? And this person ended up buying it. So basically, I think they gave it on a trial basis to me, so they can apply peer pressure on this person to make him buy that equipment. So it's extremely important that you are cognizant of that and let growth occur in its natural pace.
We go on to Dr. Saurabh's comment, and then
I think the peer pressure has few negative things and few positive things. I think the positive things are it pushes you. It's like, you know, you are standing at a lake and somebody pushes you in the water, you start swimming. So that is a positive thing about peer pressure. The negative thing is temptation. Because, you know, somebody else does, so you also are tempted to do, you know, try to follow him. But unless there is an opportunity that you see logically, don't get into that temptation. And second thing that what peer pressure can do is it can make you envious or jealous about your peers. These are the two things we should avoid about peer pressure. But growth or pushing, somebody is pushing you to, you know, perform better, that is the best part.
thank you very much, Dr. Girish, Dr. Saurabh, Dr. Radhika, and Dr. Ramurthy, who are from the previous session, who had done a great job to get us all started and going. Thank you so